Hi, I'm Joe Graydon.
And I'm Terry Graydon. This podcast of the People's Pharmacy is brought to you by Squatty Potty Toilet Stools. They create healthy toilet posture for fast, easy elimination. Learn more about toilet posture and health at squattypotty.com. That's SQUATTYPOTTY.com.
New guidelines suggest that 13 million more Americans should be taking statins to prevent heart disease. Are you one of them? This is the People's Pharmacy with Terry and Joe Graydon.
The American College of Cardiology and the American Heart Association have issued controversial recommendations about cholesterol-lowering medications. If doctors followed the new guidelines, most people over 60 would be prescribed statins. One cardiologist urges restraint.
A diagnosis of appendicitis has traditionally led to emergency surgery. A new study has doctors rethinking this reflex.
Coming up on the People's Pharmacy, we'll find out if internet use is a benefit or a hazard for mental health. And we'll take your calls and questions.
First, this news.
In the People's Pharmacy health headlines, sugar may be an unexpected contributor to death from heart disease. For decades, Americans were told to reduce the amount of fat in their diets. Food companies compensated for the loss of flavor in low-fat foods by adding sugar. Over the last several decades, sugar consumption has increased substantially. Now, an epidemiological study called the National Health and Nutrition Examination Survey has found a higher risk of death from heart attack or stroke in high-sugar consumers. People who consumed 21% or more of their calories from sugar were twice as likely to die as people who only got about 8% of their calories from sugar added to foods. Sugar-sweetened beverages, desserts like cookies, cake, and ice cream, along with candy and fruit drinks, were the primary sources of added sugar. Although it's not clear how sugar kills, there's growing evidence that multiple mechanisms are in play. Weight gain, fatty liver, and high triglycerides may all contribute to inflammation, a common denominator in chronic diseases such as diabetes, hypertension, cancer, and heart disease.
Low levels of vitamin D in the bloodstream have been linked to a variety of chronic health problems, including arthritis, diabetes, heart disease, infection, kidney disease, osteoporosis, stroke, and cancer. Now add dementia to that list. A study in the Journal of the American Geriatrics Society followed almost 3,000 older adults for 4 years. They were tested for cognitive function at the beginning and end of the study. Vitamin D levels were also measured. The investigators found an association between low vitamin D levels and a drop in cognitive performance. The scientists caution that their study does not prove cause and effect. The value of vitamin D is becoming so clear that it makes sense to have levels assessed and take steps to bring them into a normal range if they're low.
Pregnant women with low levels of vitamin D circulating in their bloodstreams are more likely to have children who develop cavities in their baby teeth. Researchers took blood samples from 207 Canadian women during their pregnancies. When their infants were just over a year old, they were given dental exams. Roughly 1/4 of the 135 youngsters in the study had cavities. Mothers with the lowest levels of vitamin D were most likely to have babies with cavities. The scientists suggest that preventing vitamin D deficiency during pregnancy could pay off with healthier teeth for the offspring, though experts do not agree on whether supplements or sun exposure is better for getting adequate vitamin D.
Don't put your money where your mouth is. A study at New York University did microbiological studies to find out what germs live on dollar bills. As it turns out, the list is long. More than 3,000 different types of bacteria were found, including some that have not yet been identified. The most common bacteria included those that are associated with acne, but germs linked to pneumonia, ulcers, and food poisoning were also prevalent. Paper money provides a good growth medium for microbes. especially when it's kept in a wallet in a back pocket. Body temperature encourages microbial proliferation. The next time you pay for a bagel, burrito, or sandwich, wash your hands before you handle your food.
Diagnostic error may be far more common than most people think. A new study estimates that up to 12 million Americans don't get the correct diagnosis when they visit their doctor's offices. The researchers analyzed 3 previous studies of outpatient diagnostic errors. They discovered a 5% error rate, with up to half of the errors carrying the potential for serious harm to the patient. That means as many as 6 million adults could be harmed annually because of diagnostic errors. This study did not take into account mistakes in diagnosis that occur in hospitals or nursing homes. Some previous studies have suggested that diagnostic error rates in such institutions could be substantially higher. Lack of a correct diagnosis means that many patients don't receive the appropriate treatment for their condition. In cases of cancer, delay can be lethal. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon. I'm a pharmacologist.
And I'm Terry Graydon. I'm a medical anthropologist. Late last year, the American College of Cardiology and the American Heart Association introduced new guidelines for treating cholesterol. Following their recommendations would put 13 million additional Americans on statin-type drugs. 87% of men over 60 would be candidates for a statin prescription. Is this the best way to treat heart disease or prevent it?
To learn more about these guidelines, we turn to the editor-in-chief of the respected journal JAMA Internal Medicine. Dr. Rita Redberg is a cardiologist and professor of medicine at UCSF School of Medicine in San Francisco.
Welcome to the People's Pharmacy, Dr. Redberg.
I'm glad to be here. Thank you.
Well, thank you very much for joining us on the People's Pharmacy. Dr. Redberg, you wrote a fascinating editorial or op-ed piece in the New York Times several months ago about the new guidelines and in particular about statins. You know, it created a lot of controversy. The dust has now settled just a bit. As a cardiologist, how do you put all this into perspective, especially for our listeners who are now so very confused?
Well, it's understandable that listeners are confused because I think, as we have done with a number of issues, the recommendations have changed somewhat, particularly in our guidelines. And, of course, some of that is due to new information, but some of that is interpreting the same information differently, and both of that occurs. But in particular, the most recent statin guidelines really changed a lot of things. The best thing I think they did was to take away from the focus on cholesterol levels, which I think is very misguided, and look more at your overall risk. So we've known for a long time that the people at highest risk aren't people that have just one risk factor for heart disease. For example, high cholesterol is just one risk factor, and you can still be at very low risk for heart disease and have a high cholesterol. Instead, what these guidelines emphasize is that you have to look at the overall risk of the person. Are you somebody who smokes and is very obese and doesn't exercise, and then also, as often happens in people that have those lifestyle habits, have high blood pressure, diabetes, and high cholesterol. And that kind of person is going to be at higher risk than someone who just has one risk factor, like high cholesterol. And they also said to stop checking LDL levels, which are used to be what we called the bad cholesterol, because actually there's no evidence to support LDL levels as targets. So I thought that was good. There hasn't been any evidence to support LDL levels as targets, although they had been suggested to be targets in previous guidelines. And I think it's good not to target those. But I also think that's part of what made these current guidelines confusing, not just for patients, but for doctors.
Well, speaking of doctors, there are a lot of physicians who are having a hard time adjusting to this concept because, for decades, They were telling their patients, oh, you've got to get your total cholesterol under 200. You've got to get your bad LDL cholesterol under 135. In fact, there were some physicians who said it's got to get below 100. And now all of a sudden they're being told, no, those guidelines weren't based on science. And they're scratching their head going, wait a minute, are you telling me that what I've been doing for the last 30 years is wrong?
Well, it's understandable that people are scratching their heads. I think it is confusing. I have never felt that we should be using those LDL targets because, I read all the studies and didn't come away with the idea that that was going to be leading to better outcomes. But that has been what we have been sort of teaching in the guidelines, so it's confusing, although I do think that part is an improvement. Like I said, I think the whole focus on cholesterol and LDL is misguided because your risk for heart disease is not just about your cholesterol or LDL number. It's really part of a big picture, and most of it's lifestyle. It is not related to your cholesterol level.
Well, speaking of lifestyle, if you go to the guidelines, and in particular the cardiovascular risk calculator, I'm still scratching my head because there are people who are, let's just say, listening to us right now in their 60s, who may be vegetarians. Mm-hmm. They may be exercising 5 days a week, running 2 or 3 miles a day. They're non-smokers. They don't have any diabetes, but they might have a little elevation in their blood pressure. It might be, 130, 135 systolic, and they may be even treating it with a medication. They go to the risk calculator, and all of a sudden it says, you're a candidate for statins.
Well, one of the problems with that cardiovascular risk calculator is that there are so many, risk factors that it can't or doesn't take into account. Joe was mentioning it doesn't take into account whether or not you're at an appropriate weight. It doesn't take into account whether or not you exercise. It doesn't take into account whether you're eating a healthful diet, whether it's vegetarian or vegan or something else.
Well, those are all really important points, and you're absolutely right. Those things are way more important than the number on that new risk calculator, which I have to say, I don't know that that's going to be around for a long time because there were a lot of issues about whether it was validated or not, and in fact, appeared that it had not been validated and doesn't really work in populations. I mean, just like you said, age was kind of the main factor in that calculator. And of course, as we get older, our risk for heart disease and for dying increases. But, the important part is what can we do to keep our risk as low as possible as we get older? And the answer is not to take statins. The answer is just what you said, to eat a healthy diet, to exercise regularly, and to not smoke. But you wouldn't know it by using that risk calculator and then trying to follow the guidelines, which I think was the problem in the way it was presented. For example, I was at a medical meeting the day the new guidelines came out, and the physician sitting next to me was a very healthy, just like you said, ate a very healthy diet, exercised regularly, but he was just on 70. And he did his risk with the new risk calculator, and it was like 17%, just based on his age. All of his other numbers were totally normal. And he told me that yesterday, the day before that, based on the old calculator, his risk had been 7.5%. So just by the changing calculator, his risk had doubled because of the emphasis on age. And clearly his risk hadn't doubled in that day. But according to the new guidelines, he would have been in a category recommended to take a statin, which I think was one of the problems with the new guidelines.
And if I'm not mistaken, there is little, if any, actual evidence to suggest that people in their 70s or 80s benefit from statins.
Well, that's absolutely correct. There's actually little evidence that people of any age who are healthy, don't have a diagnosis of heart disease, benefit from statins. I mean, if you consider the benefit lowering your cholesterol, people will get a lower cholesterol, but I would consider a benefit to be feeling better or living longer, and that has not been shown for the use of statins in healthy people for primary prevention.
Dr. Edberg, you are the editor of JAMA Internal Medicine. It used to be called the Archives of Internal Medicine, and for several years now, you, as the editor, have been shepherding this journal into publishing every so often a feature called Less is More, in which less health care results in better health. Would you talk to us about that initiative, please?
Sure, I'd love to talk to you about that initiative. So, and I have to, I have a team of editors. I'm very happy to have a wonderful team of editors. And Deborah Grady, my colleague, is the section editor for Less is More. And we actually started that feature a few years ago when Deborah and I were talking. It was shortly after the U.S. Preventive Services Task Force, and they had reviewed the evidence on risks and benefits of mammography in women ages 40 to 49 and said that the risks exceeded the benefits. And as you probably remember, that got a very negative reception. And we were talking about why people were really not ready to hear that women between the ages of 40 to 49 get more risk, more harm than good from mammography, and thought that the message probably about the harms of mammography in that age group, like unnecessary biopsies, surgeries, and chemotherapies, was not coming across. And that's really how we launched the Less is More series, because while that is one example, there are a lot of examples of things we do that have no known benefit, and everything has some possibility for harm. And so we thought it was a good time to start focusing on what things could we do to decrease or stop procedures or drugs or devices treatments when they have no known benefit and have definite harms. And that's how we launched the Less is More series.
Along the same lines, you wrote an article for, I believe, the New York Times, an article for the popular press, unlike JAMA Internal Medicine, which is for doctors, in which you suggested that maybe we are giving ourselves cancer with too much CT diagnostic screening. Would you expand on that, please?
Sure, I would. And we actually, you're right, that was in the New York Times, so for the popular press, although we did cite some research that had been published in Archives of Internal Medicine and now JAMA Internal Medicine that documented that. And basically, we had published a study from the National Cancer Institute a few years ago that looked at the CT scans done in 2007 alone. And the estimates are that those CT scans, just from that 1 year, will cause a projected 29,000 excess cancer cases and 14,500 excess deaths over the lifetime of those exposed to the CT scans. And as you know, the CT scans are occurring every year, and so it's now estimated that 3 to 5% of all future cancers are going to result because of medical imaging.
You're listening to Dr. Rita Redberg. She's a cardiologist and professor of medicine at UCSF School of Medicine. She is the chief editor of JAMA Internal Medicine.
We need to take a short break. When we come back, we'll talk more with Dr. Redberg, and we'll take your calls and questions. What do you think about the recent statin guidelines? What's your experience with a statin like Lipitor, Crestor, or Zocor? We welcome your calls at 888-472-3366. Email us radio@peoplespharmacy.com. That number again, 888-472-3366.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible by Redix Industries, makers of utterly smooth creams and lotions that moisturize deeply to make dry skin feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
And by Squatty Potty Toilet Stools, creating healthy toilet posture for fast, easier elimination. More information about how toilet posture affects your health at squattypotty.com.
If you'd like to order a CD of this show, you can call 800-732-3333. 2334. Today's show, number 943, or you can find it on the website, peoplespharmacy.com.
Today, we're talking about the health news that matters to you. A few months ago, new guidelines for cholesterol control were issued by the American College of Cardiology and the American Heart Association. Implementing these recommendations would put the majority of older Americans on drugs like atorvastatin, lovastatin, and simvastatin.
What's your experience with such medications? We'd love to hear your story. Have these drugs lowered your cholesterol without side effects? Or have you had trouble with muscle pain or other reactions? Our lines are open at 888-472-3366. You can also send us a tweet at People's Pharmacy or an email, radio@peoplespharmacy.com. The number again to join the conversation, 888-472-3366.
We're talking with cardiologist Rita Redberg. She's professor of medicine at UCSF School of Medicine in San Francisco and editor-in-chief of JAMA Internal Medicine.
You know, there was a time when people went to the doctor because they felt bad and they wanted to be, helped to feel better. Today, a lot of times we go to the doctor feeling great and we come home with prescriptions that make us feel bad. So, how do we put all of this into perspective?
Things are changing, and I think what the message we were trying to give both in the journal and in the op-eds that we talked about is, there are certainly lots of advances in technology, lots of things we can do for sick people. But you're right that most of the benefits and things we can do to improve health are for sick people or people with disease. And where things get a lot dicier or the evidence is really not well established is when we are intervening on healthy people or people without symptoms. And, those are the times the public needs to have a more informed discussion than commonly occurs today. The American Board of Internal Medicine Foundation has launched the Choosing Wisely campaign, and about 60 professional societies have now signed on and each come up with a list of the top 5 things that patients should be questioning or at least discussing with their doctors if they are recommended for them. And a lot of those are the kinds of things that we've been already talking about, either medical imaging tests, which I don't want people to walk away and think they would never need a CT scan. There are, of course, times that CT scans are appropriate and helpful, but we also know there are a lot of times when they're not necessary. And so it's just important to have more of a discussion, to feel free to talk to your doctor, particularly when you're feeling well, about what are the benefits to you for this test. How will it make a difference in your management, and how will that lead to longer life or a better life for you? Because those are important questions before agreeing to have any kind of test, particularly any one that has risk, like one with radiation or an invasive test.
And I assume the same thing holds true for medications.
Absolutely, for medications. Like I said, we included statins, which we had started talking about in our Less is More series, because statins for healthy people, we think, generally have more harms than benefits.
Dr. Rita Redberg, thank you very much for talking with us on the People's Pharmacy today.
It was my pleasure. Thanks so much for having me.
You've been listening to Dr. Rita Redberg. She's a cardiologist and professor of medicine at UCSF School of Medicine in San Francisco. She's editor-in-chief of JAMA Internal Medicine.
A few weeks ago, there was an article in the European Journal of Preventive Cardiology in which the authors concluded only a small minority of symptoms reported on statins are genuinely due to the statins. Almost all would occur just as frequently on placebo. And the reason I'm so confident about that's a direct quote.
And this has been widely understood as a statement that statins have virtually no side effects. Well, does that tally with your experience? Give us a call. The number's 888-472-3366. Again, if our lines are full, which they are at the moment, you can email us, radio@peoplespharmacy.com, or send us a message through Twitter @peoplespharmacy. Where do we go first, Terry?
Well, let's go to Point Pleasant, West Virginia, and talk with Patrick. Patrick, welcome to the People's Pharmacy. What is on your mind?
Hi, Joe. Hi, Terry. I was subjugated to Crestor and Zocor for about 6 years in the late 80s, early 90s, and it got progressively to that deep muscle pain. They thought I had MS.
Oh,
and
my.
When they said, we need to do a spinal tap, I said, enough's enough, and quit. And about 6 months later, most of it had lifted. I lost use of my legs at times and, just lost strength in the arms, just deep muscle pain. And my neurologist feels confident that that's the reason I have some neuropathy today, 20-some years later.
Well, Patrick, thank you for sharing your story. This is a very controversial topic, needless to say. As Terry just mentioned, the article that was published just several weeks ago said really there is not a problem with muscle pain or nerve pain associated with statins based on the randomized controlled trials. But we've heard from hundreds, maybe thousands of people just like you who say, hey, I really had problems. The pain was unbelievable. And when I stopped the medicine, the side effects began to go away. But for some people, Terry, they linger.
There are a few people for whom the side effects don't seem to go away, or we haven't found the time frame in which they go away. It sounds, Patrick, as though it took about 6 months before you were feeling better.
Yes, and still 2-3 years later, I would have episodes
Uh-huh.
of pain.
So it clearly it was a situation in which the side effects were severe and they did linger. And, I don't know whether something like that would show up in the randomized controlled trials.
Probably not. We go to Dallas, Texas. Tom, we understand you've recently had a quadruple bypass.
That's correct. So I'm a newbie to this whole deal, and I was never very good at taking any kind of supplemental things in the morning, vitamins and so forth, and never had any markers myself or within my family 2 generations back. And I had just a burning in my chest that led to my primary care doctor, to do some investigation, and I ended up with a quadruple bypass as a result. So I'm just now beginning to start to take these statins and the drug that I'm prescribed is Lipitor. And early on, I had a lot of, now the surgery was early February. Early on, I had quite a bit of overall muscle ache to my body, but that has since gone away. The LDL was slightly elevated from last year to 124 down to now 56. So psychologically, I feel better. But what I'm hearing here is that that's not really a good marker anymore. And I understand that this disease is progressive. What can I be doing? Because I'd just as soon like to avoid another one of these.
Well, clearly, you are the poster child for statins. And, I think what we've said over the last couple of decades is that there are some people who really do benefit, and that's what the studies demonstrate. Those are people who have diagnosed heart disease, and clearly, after quadruple bypass, you have heart disease. There's no question about that. And statins will reduce your risk of having an event, like a heart attack, or dying. And so, you're the kind of person for whom statins work absolutely best. It may be the cholesterol-lowering effect. It may be an anti-inflammatory effect. It may be both.
And one of the things that you can do, Tom, is get in an exercise program that's supervised so that it's appropriate for someone who has just recovered from quadruple bypass. But that has been shown to be very, very helpful.
So exercise, appropriate diet. We keep hearing that the Mediterranean diet is the perhaps best
the way
diet.
to go.
Mm-hmm.
Yeah.
Clearly not smoking, reducing your stress level, and the statins. It's it's a whole package. It's not just one thing. Does that make sense?
Absolutely, and I am participating in a cardiac rehab follow-up after the surgery that's also, put on by the hospital as well.
Excellent. And good luck with that.
Thank you for sharing your story, and let's hope that the statins do what they need to do without side effects. I would think that most people, maybe 75 to 80%, do not experience muscle pain, weakness, or any kind of peripheral neuropathy, and we'll keep our fingers crossed that you're one of them. Thank you for your call.
In Davidson, North Carolina, Chris, welcome to the People's Pharmacy.
Hi, Terry and Joe. My name is Chris Magruder, and I'm an integrative pediatrician. I studied under Dr. Weil, and before I went to see Dr. Weil, my cholesterol issues were around 250. I had a strong family history. Father had double bypass and some heart attacks earlier on. So I did follow the standard course of Lipitor and had the same symptom response of myalgias. I was a competitive soccer player. Didn't work out very well. So after 6 months, I decided that wasn't the way and started doing a little more research into nutrition. And around that time, started the fellowship in integrative medicine. So I went on a anti-inflammatory diet, which I know you guys have talked about many times, and got my cholesterol down to around 210. But at the time when we were still chasing the number, couldn't get it below that. So I was still concerned that I had high risk. So at that time, I was actually getting some arthralgias and mild arthritis and went on a gluten-free diet. And interestingly enough, somewhere thereafter, I tested my cholesterol again. It was down to 150. My HDL slipped from 30 to 60, and my risk appeared to be gone. Again, this is pre these new guidelines. But I'm wondering, again, I think maybe some of this is, according to Alessio Fasano's work, maybe some non-celiac gluten sensitivity. I just wanted to share that with your listeners.
Well, I think that's fascinating, and I'm sure glad that you have shared it, Chris. So you don't believe that you actually have celiac disease, but that you are sensitive to gluten. Is that correct?
Correct, and I'm actually tested negative on my celiac markers are negative, and so is HLA DQ2 and DQ8, the haplotype markers. So I don't
the
have
genetics,
celiac.
right?
Correct. I do not have celiac, but absolutely, when I went off of gluten, many symptoms that I had disappeared, and it was just serendipity that when I went and checked my cholesterol, it all of a sudden normalized. And actually, the liposcience test afterwards showed that my particle size actually flip-flopped.
That is
fascinating story.
Yeah. And, Chris, I have to tell you, we're hearing more and more from people who say, I don't have celiac disease, but I do seem to be sensitive to gluten, and you're one of them. Before we say goodbye to you, I've got a question. You are a pediatrician, is that correct?
Correct.
So what do you think about the state lawmakers in Connecticut? They are proposing legislation that would prohibit milk, whole milk, in daycare. They say even 2% is unacceptable, and that in order to curb childhood obesity, only skim milk can be served. We're kind of curious. Your thoughts?
It makes no sense to me. Frankly, I'm not a big fan of dairy. I'll just put that out front because of all the issues of milk protein intolerance that I see in children. But I don't think the obesity epidemic is going to be related to the fat in dairy. I think the biggest issue I see in my patient population is the unbelievable overconsumption of refined flour and sugar. And I think before we tackle dairy, we should really be looking more at processed foods.
Well, thank you for sharing that. We always worry a bit when legislators make health decisions like this. It's like, wait a minute, have they studied the science?
Yeah, and I don't think they do.
All right. Thanks so much for your call, Chris.
Bye-bye.
And Joe, to answer your question about the science, there actually was a study, a longitudinal evaluation of milk type consumed and weight status in preschoolers. So these were kids between the ages of 2 and 4. It was published in the Archives of Disease in Childhood about a year ago, and what they found was that kids drinking skim milk actually were a little heavier.
What?
They gained a little more weight in the course of those 2 years.
So the people on skim milk, the kids on skim milk, actually did worse.
In terms of their, they did. They gained more weight.
Right.
Let's put it
That's
that
doing
way.
worse.
Yeah. I mean, you do want kids to gain weight, just not too much weight.
Right. Well, maybe those legislators need to look at the science. Let's go to St. Petersburg, Florida. David, we understand you're a surgeon.
Yeah, hi, Joe and Terry. I'm a neurosurgeon, and I've got just a couple of comments. One is on the study, which is just another example of people abusing population health and not focusing on individual patients, and it'll turn into legislators doing things they shouldn't do. But I had a heart attack a couple years ago, and I got put on a Zocor, and that just killed my muscles. I could barely move. I was in pain. I had to go to the ER thinking I was having another heart attack from the muscle, the chest wall pain in my muscles. My CPK shot up to 1,000.
Wow.
We adjusted doses. I went on to Crestor after Zocor. Same problems. Couldn't move. And I finally got off the stuff. It was great for my cholesterol. It really controlled it well, but I could barely function. And then went off it, tried dose adjustments, tried adding CoQ10. That didn't help. Tried Ribinol. That didn't help. And finally got on Lipitor, which is not studied in the preventative mode for this problem, but it works. It got my cholesterol under control. I'm now going up on my doses. I'm tolerating it well. I play golf actively, and I have taken the CoQ10, although finally I weaned myself off of that, and I'm still not having muscle problems.
And what dose are you taking?
I'm up to 20 milligrams now.
Well, that's fascinating because it turns out that some people do react to one statin, but not another. And it sounds like you're doing well on atorvastatin and didn't do well on Crestor. And so, it's an individual situation, although I have to tell you, some people are so sensitive to statins that they'll even react to red yeast rice. Dr. David, thank you so much for calling and sharing, and we're glad that you're now able to go back and enjoy golf and presumably continue neurosurgery.
I am, and don't believe those badly done studies that focus on population health rather than individual results.
Bingo. Amen. We completely share your belief about individual personalized medicine. Thank you for calling.
Thank you.
And Joe, the doctors who were gloating about how wonderful the risk calculator is, because they did have a meeting this week and they were bragging about their great risk calculator, but in the what they published about it, they did say, of course, everything needs to be personalized.
Well, we do need to take a short break, but when we come back, talk a little bit more about statins, but we'll also talk about coffee against diabetes. And we'll take more of your calls at 888-472-3366. If our lines are full and you'd like to get on board, email us, radio@peoplespharmacy.com.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redix Industries, makers of utterly smooth creams and lotions, helping dry, cracked skin feel utterly soft and smooth. The number's 800-345-7339, online at uttercream.com.
And by Squatty Potty Toilet Stools, creating healthy toilet posture for fast, easier elimination. More information about how toilet posture affects your health at squattypotty.com.
You can purchase a CD of this show. You can call 800-732-2334. It's show number 943, or you can find it on our website, peoplespharmacy.com.
Today we're talking about the stories behind the health headlines. Our lines are open for your calls and questions if you have a story to share. And you can call us at 888-472-3366. You can email us, radio@peoplespharmacy, or you can join the conversation by way of Twitter. We're at People's Pharmacy.
Now, before we talk about coffee, which I think is fascinating, it's a really cool study, and there is a dose-response curve, Terry, which, as you know, I always get very excited about.
Oh, dose-response curves, they make a pharmacologist's heart go pity-pat.
It's true. But first, do you cheat on your diet because you're taking a statin? there's a new study out. It suggests that statin users have gradually increased their calorie and fat intake over the years, and that's based on data in the National Nutrition Studies. Some folks find they don't have to be as careful about their diets to keep their cholesterol under control because the statin worked so well. Have you found yourself in that situation? Our lines are open at 888-472-3366. Or again, as Terry mentioned, the email address is radio@peoplespharmacy.com. I found this study to be really quite amazing, Terry.
Well, this is the study that it actually doesn't prove that people taking statins are putting butter on their steak, as the headline suggests. But what it does show is that a lot more people who are taking statins are eating more fat, more saturated fat, and more calories. Now, that just might be because doctors are prescribing statins to the people who are eating more fat. There are more people taking statins.
Well, this was 28,000 adults. This was between 1990 and 2010. And they looked at calorie consumption and fat consumption in the first year and then in the last year. And what they found is that people went from 2,000 calories daily to 2,192 calories on average daily on statins.
Not necessarily all of them the same people.
No, but they also increased their fat consumption
Yes.
from 72 grams to 82 grams. It's sort of like, hey, I can have the milkshake and the burger and fries. I'm taking a torvastatin. When I go see my doctor, my numbers will be fabulous, regardless of what I'm eating.
Right. And, and actually we might not even be that worried about fat depending on what else is in your diet. But if you're eating fries and shakes and burgers with buns, maybe not so great.
By the way, diabetes increased as well from 22% in the first year to 29% of statin users. And the data now does suggest that statins increase the risk of diabetes by about 20%.
Shall we talk to Robert in Dallas, Texas?
Let's do it.
Robert, welcome to the People's Pharmacy.
Hi, Joe and Terry. How are you?
We're doing well. What's on your mind?
I have a question. When you state studies and everything, and so it's like the statin study, do you actually do research on who's actually financing and conducting these studies? Because the people that do the studies, they're actually financed by somebody to do that study.
Yes, we often do. We often look at where the funding comes from. We don't always get into the weeds as much as we should about the author's disclosures because they're not usually part of the study, the publication itself. You have to go into the additional information that may be listed online. It's worth doing. It's something we should do a little bit better. For example, there's a very interesting study, a meta-analysis on vegetarian diets and blood pressure that was published quite recently. We wanted to talk about it. And it turns out, and this should not be a big surprise, that the meta-analysis shows that people who eat a vegetarian diet have lower blood pressure. And this is great. It's a good finding, and it's pretty strong. It's a well-done study. One of the authors, most of the authors are Japanese, and I think that the study appears to have been funded, just fine. But one of the authors is a guy named Neil D. Barnard, MD, and he has an agenda, a vegetarian agenda. He's with, what is it, Joe?
I think he's with PETA and with another organization as
Physicians for Social Responsibility. But their agenda is to promote vegetarianism. So we can say it's a good study, it's strong, but it does have this little question attached to it because of his agenda.
I think your point is very well made, but here's the problem. Most of the large drug studies that are conducted in this country, the randomized controlled trials, are in fact funded by the pharmaceutical industry. Does that contaminate them is the question. And I think what the Food and Drug Administration would say is a good study is a good study. If it was well conducted, if it passed peer review, if it ends up in the New England Journal of Medicine, it doesn't much matter who paid for it if it was conducted correctly. And, I think I'm a little bit of a agnostic on this issue.
Joe, we got an email from Elliot who has a suggestion for us a way to think about that placebo study on statins. He says, we already know that the power of placebo is a real thing. So that's thing one. Thing two, a lot of people believe statins cause side effects. So having a study that shows that a lot of people on placebo experience statin-type side effects doesn't prove that statins don't cause side effects.
Quite true. Well, let's talk a little bit about coffee before we go back to the phones. This is a lovely study, I have to tell you. I as a coffee drinker, I am biased, okay? I admit it. I'm not completely objective here. But this is a study that looked at over 100,000 adults. And it found that there is a dose-response relationship between coffee drinking and diabetes. People who drink 3 to 5 cups of coffee a day had a significant reduction in type 2 diabetes. Now, this comes from 3 major U.S. studies, the Nurses' Health Study between 86 and 2006, and then again from 91 to 2007, and the Health Professionals Follow-Up Study between 1986 and 2006. And there's a lot of people in these studies. What they found was
there are a lot of people in these studies.
When people increased their coffee consumption by more than 1 cup a day over 4 years, their risk for developing type 2 diabetes over those 4 years dropped by 11%. That's compared to people who didn't boost their coffee intake. People who drank 1 less cup of coffee a day over this period of time had a 17% higher risk for diabetes over the next 4 years. So people who increased coffee, less diabetes. People who reduced coffee intake, more diabetes.
So does this mean that if I want to reduce my risk of type 2 diabetes, I have to start drinking coffee every day?
Well, no.
I did start drinking coffee several years ago when I read that French women who had coffee at lunchtime had a lower risk of type 2 diabetes. This finding on coffee is not at all new. This is a real confirmation of what we have already seen from other population-type studies showing that coffee consumption is associated with a lower risk of type 2 diabetes. But I don't want to drink coffee every day.
And so you should not. Just keep exercising, keep doing the karate. I think you'll be good. Okay, let's go to the phones and talk to Phyllis in Boca Raton, Florida. Hi, Phyllis.
Hello. My husband has been taking statins of every kind for years, including red rice yeast, and had terrible cramps. He had to give it up. And then he was prescribed fluvastatin sodium, 40 milligrams, and he takes it every night with CoQ10. His statins have gone considerably down, and he doesn't have cramps. This is the first time in many, many years.
Well, that's fabulous. And again, proving, Terry, that everybody's different.
Right.
Personalized medicine, that's what the People's Pharmacy is all about. We go to Madison, Wisconsin. Hi, Terry. What's your story?
Yes, hi, Joe and Terry. I am calling because I have been concerned about this new study because I'm on Lipitor, and I've had a lot of trouble with weight gain no matter how careful I watch my diet, and I have developed type 2 diabetes, so it has concerned me.
Well, the type 2 diabetes is actually the one side effect that research that said, no difference between statins and placebo on side effects. They did say, but of course the increased risk for type 2 diabetes, that one is real. You don't develop that on a placebo.
What I find kind of fascinating is Dr. Steve Nissen, our cardiologist consultant from the Cleveland Clinic, says, well, even if statins give you diabetes, you should still keep taking your statin. And I keep wondering about that advice because if the statin gives you diabetes and diabetes has all these other risk factors, I'm not connecting the dots. I'm having a hard time. Terry, thank you for sharing that. And, of course, you'll want to talk to your doctor about this statin diabetes situation. Terry, we're rapidly running out of time, and I promised I would talk a little bit about appendicitis.
Yes, you need to do that.
Without surgery. I mean, this was an interesting kind of a preliminary case. It was in the Journal of the American College of Surgeons. They looked at 77 children and gave them the option, after they looked, this was uncomplicated. I have to emphasize that, uncomplicated appendicitis. And this is
not ruptured appendix.
Not ruptured. And this is a case where CT scans make a lot of sense. They gave them the option of antibiotics versus surgery. 30 chose antibiotics with their parents' approval, of course, and 47 picked surgery. Turns out that 93% of those who took the antibiotics were feeling better within a day and recovered faster. 3 days recuperation on the antibiotics versus 17 days recuperation after the surgery. 3 of the patients in the antibiotic group did require appendix removal in the next 30 days. But the point of the research seems to be that uncomplicated appendicitis may be treatable without surgery, just with antibiotics. And this is something that's an evolving process.
This seems to fit into our less is more theme, doesn't it?
It does. Now, what's this about computers and depression?
Well, it turns out that we sort of think of older people as not necessarily being online all that much. But it turns out that's the wrong way to think.
Yeah, baloney.
Of course. There was a research done on 3,000 plus retired men and women living in the community, not in nursing homes, and they were assessed for depression, and they were also independently asked whether or not they were online. Well, it turns out that the ones who were online were a third less likely to suffer from depression, and we think that it's because, of course, when they're online, they're connecting with friends and family. They're using email. They're using Facebook. They didn't actually ask them what they were doing online, but it seems very clear that being online can be an advantage for older folks. And the researcher said adult children who are thinking of getting their parents online should think about the interface. Don't give up, but do try and find, something simple and be patient. It takes a lot of repetition.
Well, there is some danger of being online all of the time.
Well, there is indeed.
You might catch word flu.
You could catch word flu. And of course, what we're talking about is a fictitious epidemic of word flu that shows up. It's very dangerous, it's very scary, and it's in our daughter's new novel, The Word Exchange by Elena Graydon. It's really exciting.
Shameless parental pride.
Yes.
Are you ready for Joe's rant?
Joe's rant? Yeah, I'm ready.
Okay, warning, rant alert. This study that has just come out from New York University's Dirty Money Project found that currency is contaminated. Surprise, surprise. Your dollar bill, your $5 bill, your $10 bill.
Well, how many people have touched it?
Well, that's the point.
And where were their hands?
Exactly. They found 3,000 types of bacteria on the dollar bills that they tested. The bacteria included Staph, I think it was Staph aureus. They found bacteria that causes foodborne diseases. They found bacteria that causes stomach ulcers. They found all kinds of nasty stuff. And it turns out these bacteria grow on dollar bills or $5 bills, on paper money.
Well, paper is probably a nice medium for them.
And when you stick them in your wallet and then put your wallet in your back pocket,
you have it at not room temperature, but body temperature, which is a lovely temperature for most bacteria.
So here's the rant. Not that we can't handle money, we can, but what drives me crazy, I mean, I just can't tell you how wild I get.
Well, presumably after you handle money, you want to wash your hands.
Right, but here's the deal. The people who take my money at the coffee shop and then grab my cup with their hands, their sturdy hands, and they touch the rim, and then they put the lid down with the palm of their hand, and they don't even think twice.
Well, you could make your own coffee.
Yeah, I could, but there are times when that's, inconvenient when we're out and about. And so it's just like, wow, why aren't people thinking? And, sometimes people handle money and then they give you your sandwich or your burrito or whatever. So I'm asking people who handle money
not to handle food or wash their hands.
Or coffee.
In between.
Absolutely.
Okay.
So that's my rant for the day. Finally, aspirin. Are you ready for this? Aspirin
I don't know, are we?
against colorectal cancer. The risks are dramatically lower, especially if you have the right gene. And this is a gene that most of us have in our digestive tracts. It turns out that if you do have that gene, if you have that enzyme, your risk of colon cancer goes down by about 50%.
If you take aspirin.
If you take aspirin. And it's called the 15-PGDH genetic enzyme.
Any word on how much aspirin it requires? Because aspirin can also have
side effects. Absolutely. You need to check with your doc on this. But 2 regular strength aspirins a week, which is sort of equivalent to a daily dose of 81 milligrams. That's sort of a baby aspirin. Well, I'm sorry we didn't get to Sarah in Camden, South Carolina, who did cholesterol research and says continue taking your statins for someone who never had, and I can't read what she says next.
Elevated cholesterol, but a minor heart attack.
Right.
So the answer is yes, people who have had a heart attack, even a minor heart attack, do appear to benefit from statins.
Well, that is all the time we have. Thank you so much for listening to The People's Pharmacy. If you'd like to continue the conversation, you can do so on Twitter, on Facebook. You can email us. It's all there at peoplespharmacy.com.
Lynn Siegel produced today's show. Sophie Copeland provided technical assistance. Al Wadarski is the engineer. And Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
To order today's show, you can call 800-732-2334. Today's show is 943. You'll also be able to find it on our website, where you can find prescription medication information, dietary supplements, herbs, and home remedies. Share your own experience with statins.
That website is peoplespharmacy.com, and you can sign up for our free email newsletter or subscribe to the free podcast of our show.
You can also share it with a friend. It's all there, peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Please join us again next week when we talk with Dr. Susan Love about new approaches for breast cancer.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.